Hello everyone, today we continue with our discussion of the cardiovascular summary high yield scenarios. Okay, so another high yield scenario, they tell you, okay, there is a patient who's 65, has gout and hypertension. What's the best next step treatment? So what medication that you give for somebody who has gout and hypertension, like to treat their hypertension? The answer is metoprolol and lisinopril. Okay, so now this is bring up a discussion what medications for hypertension in patients with gout. So the one that increases gout flare-up are diuretics, thiazide, loop diuretics, beta blockers. The one that decreases risk of gout flare are losartan, calcium channel blocker, amlodipine. The one that has no effect on risk of gout, ACE inhibitor, herbs other than losartan. Okay, so now let's go to the second question. Okay, so if you see, like, let's say 50-year-old guy came in with tender, they tell you that came in after cardiac catheterization, okay, heart cath, and has tender mass below the right inguinal ligament. What does that make you think? Okay, so heart cath and then develop tender mass below the right inguinal ligament. What's the best next step in this patient? So what do you think that happened here? Here there may be hematoma. Okay, so what you want to do, you want to do Doppler ultrasound. This is can be common scenarios. This is important for the boards. Okay, another case scenario that we can deal with. So 60-year-old patient came in, wake up 3 to 4 times per week with substernal chest pain. Okay, so someone has like recurrent frequent chest pain and they feeling fatigue, okay, and then BMI is high. What do you do? Substernal chest pain, palpitations, okay, BMI like 35, let's say. So what is best next step in this patient? Okay, at night. So you want to do polysomnography, and the reason is there are cardiovascular effects of obstructive sleep apnea. Could cause systemic hypertension or difficult to control hypertension, could cause pulmonary hypertension, coronary artery disease, and this patient could have nocturnal cardiac arrhythmia, which is common with obstructive sleep apnea, could cause bradycardia and asystole. It can cause atrial fibrillation, can cause non-sustained ventricular tachycardia, and can cause heart failure. So you want to check polysomnography to diagnose the obstructive sleep apnea. Okay, another high yield scenarios. Let's say they can ask you about a patient like who's 31-year-old white male who has came in with a murmur for pre-employment physical, okay, and then the murmur says wide fixed splitting of S2, second heart sound. So what explain this murmur? Why would someone have this wide fixed splitting, the wide fixed splitting of the S2? And the answer is increased flow through the pulmonic valve. Now you can ask yourself, what could cause that increased flow through the pulmonic valve? It is ASD, because that's what you know. This is the only disease in the world ever causes wide fixed splitting of S2. So they know, everybody knows it's ASD, right? So they're not gonna ask you about that. They're gonna tell you why is that? Because of increased flow through the pulmonic valve. Okay, now another case, they bring you, okay, 25 patients with Marfan syndrome or whatever, like connective tissue disease, came in with faint early diastolic murmur. Okay, and then the question would say, what would you do next? What's the best next step? Okay, they can give you a picture of somebody with Marfan or so. Okay, so what would you do? Anyway, like somebody you have early diastolic murmur, what does that mean? Like early diastolic murmur. And the way you next step would be echo. You gotta do echo to see what causing that. Early diastolic murmur, this is aortic regurg. Okay, so if you think aortic stenosis is like systolic murmur, mid-systolic, if the aortic stenosis worsen, goes to the late systolic, and then if regurg, then this goes early diastolic. Okay, so that's what you want to do. You want to do echo, okay, for aortic regurg. Other features for Marfan syndrome: decreased upper to lower body segment ratio, increased arm height ratio. You can also see pectus deformity, scoliosis, kyphosis, joint hypermobility. There's in the eye can cause ectopia lentis. Cardiovascular wise can cause aortic dilation, aortic regurg, and pulmonary can cause spontaneous pneumothorax from apical blebs. Skin can cause inguinal hernia, incisional hernia, or skin striae. Okay, so these are the options you can have with the Marfan syndrome. Okay, another high scenario. They tell you, okay, someone, a patient like who's 50-year-old came in, 50-year-old woman came in with lower extremity swelling. Okay, so which one, because of amlodipine, she takes just on amlodipine, which one prevent the swelling? What prevent swelling in amlodipine patients? Okay, and this they want you to know that if you add ACE inhibitor, sorry, so ACE inhibitor could decrease the lower extremity swelling associated with amlodipine. Okay. Now, another question they can tell you, they bring you another case scenario based on a patient with a prolonged QT, okay? And they tell you what to avoid, okay? You avoid levofloxacin, okay? Other medications you want to avoid in this patient: diuretics, Zofran, antipsychotic, Haldol, quetiapine, risperidone, TCA, selective serotonin reuptake inhibitors, citalopram, amiodarone, sotalol, flecainide, ranolazine, anti-infective drugs like macrolide, fluoroquinolone, antifungal. Other metabolic disorders, like somebody with electrolyte imbalances like hypokalemia, hypomagnesemia, hypocalcemia, can cause long QT. Other things, starvation, hypothyroidism, can cause long QT. Things that causes bradyarrhythmia, like sinus node dysfunction, atrioventricular block, can cause long QT interval. Others, like hypothermia, myocardial ischemia, infarction, intracranial disease, HIV infection, can cause long QT interval. Okay. Now, another case, let's say 55-year-old male with small ulcer at the tip of right big toe, right? So this is pain with walking. We kind of discussed that in the previous video. And then the ABI is like 1, normal, but there's very high suspicion for like a peripheral artery disease. ABI normal, ABI is fine. So what would you do in this best next step? In this patient, you want to do exercise testing with repeat ABI. Okay, so you do ABI exercise testing, okay, so that you give you a more accurate picture. If it's less than 0.9, this is diagnostic of peripheral artery disease. Other option they can give you, like CT angio. Usually always go with less invasive. You can do computed tomography of lower extremity. Maybe in real life that would you do, but in this patient, if you have a kidney disease or for the test purposes, you gotta do exercise testing ABI. Always go less invasive, okay, in a summary. Okay. Now they bring you another patient with like a 70-year-old, 75 with orthostatic hypertension, right? And then they will tell you, okay, increased risk for what? Okay, you can increase risk for all-cause mortality. This is orthostatic hypertension, can cause increased risk for all-cause mortality. Okay, so just summarize the second part of the 10 questions. Like to just summarize: hypertension with gout, what do? You give metoprolol, lisinopril. Tender mass after heart cath, you want to do Doppler ultrasound, polysomnography for say increased pulmonic flow with ASD. Early diastolic murmur echo. ACE inhibitor with amlodipine is a good idea to decrease swelling. Prolonged QT, avoid Lavoquin with diuretics and antipsychotics. Small ulcer, you want to do exercise testing with ABI. And orthostatic hypotension, increased risk for all-cause mortality. Okay. Thank you for listening, and we'll go to the next 10 questions.